Thank you for joining us for the program, The Future of Healthcare. Our first speaker is Peter Egan, a partner and practice group leader for the healthcare team at Nixon Peabody in New York. Peter represents healthcare industry clients in complex business transactions and with compliance and regulatory analysis. He also leads the firm's behavioral health team. He helps healthcare and life sciences companies structure transactions to comply with federal and state fraud and abuse laws and regulatory issues. He also regularly advises healthcare management companies and their provider clients on whether proposed services and compensation methodologies are permissible under state law. Our next speaker is Julie Kass, a shareholder at Baker Donelson in Washington, D.C. Julie is a healthcare regulatory attorney with a practice that encompasses a wide range of services. She has deep experience related to the fraud and abuse aspects of Medicare and Medicaid, including the federal, Stark, and anti-kickback laws, OIG civil money penalties, and exclusion authorities. Her depth of knowledge offers clients the trusted strategic counsel that is required in this ever-changing healthcare landscape.
Hi, everyone. My name's Peter Egan. I'm the healthcare practice group leader at Nixon Peabody. I'm based in New York, and I'm with Julie Kass.
Thanks, Peter. I'm Julie Kass. I am at the law firm of Baker Donelson, and I work out of our Baltimore and DC offices. And we're really happy to be with you to discuss some of what is going on in the future for healthcare in these crazy times that we're having right now. And how it might be changed by the COVID crisis that we're experiencing in the US and around the world. I think one of the biggest things that we have heard about and are talking about and changes that's coming about now, but might be here to stay, is in the telehealth area. Clearly, because people aren't going outside of their homes, a lot of their medical services and medical care is coming through telehealth. People engaging with their physicians or other practitioners through video rather than going in the office. And telehealth has sort of been a long time coming to our healthcare system here because of limitations previously on reimbursement. So to date, reimbursement for telehealth has been very limited. It's been mostly in rural areas that have been designated as such. It's been for limited kinds of services, so not so many services. It's been limited in the types of people that can provide those services, mostly physicians, and it had to be both video and audio. So there's been lots of limitations, and those limitations really were a hamper on reimbursement and probably held back telehealth. And they've removed almost all of those limitations for the public health emergency. And I think the question is going to be, how long will those limitations last, and whether they will renew those limitations or bring them back once the public health emergency with respect to COVID is over. Peter, do you have thoughts on that?
Sure. So, because of the crisis, it was astonishing. We've heard from several hospital and system clients, they went from doing 0 telehealth visits to something like, you hear numbers like 1,300 visits a week. So there's obviously a tremendous desire on the part of the patients to do telehealth. And it's convenient, right? I mean, you no longer have to travel to and from the doctor's office. You don't have to sit in that waiting room. The providers like it for a whole bunch of reasons, not the least of which is there are very few no-shows. People show up for their telehealth visits. So I think it's going to be very, very difficult to put the telehealth genie back in the bottle, right? Especially when you think about Medicare and the population that it serves, your older folks, they're going to love this. And I think they're going to keep doing it. And that will put pressure on the commercial payers to continue to reimburse for telehealth services. So, like everyone else has said for the last 6-8 weeks, I think telehealth really is here to stay. That then raises a whole bunch of interesting questions. I'll throw out one which is actually kind of basic and economic, and then I'm sure we can get into the more sort of clinical aspects of this. But I had one system chief operating officer who said to me that when dust settles, he's looking forward to shedding 1/3 of his medical office space because he just doesn't think he's going to need to have that many patients come into the office, right? He's going to continue to do these services by telehealth. That would obviously have huge ramifications for the larger providers out there.
I think that the telehealth is here to stay, but it will be interesting to see in which form. As they've rolled out the waivers for telehealth, first it was, we will pay for the E&M codes, the evaluation and management codes, for physicians that usually see people in the office at the same rate that we pay for them if you're in the office. And actually, at first they said, we'll pay for them, but they used a place of service code that would actually not have paid for that facility fee, that office part of the fee. They rolled that back and said, no, we'll pay as though you are in the office with a place of service in the office. And then they said, but you had to have video. And then it moved from you have to have video to video and audio only is fine. And we'll pay under some audio only codes. And we will still pay as though it is an in-person visit. I think one of the things that might happen based on the way Medicare generally reimburses for these services is it's based on costs. And if you're talking about shedding your office space costs because you don't have all those physicians and you don't need all the space, when they actually put telehealth in permanently, I think one of the big issues they're going to grapple with is exactly how much they're going to pay for a telehealth visit. And whether they pay for the telehealth visit when you have video even differently than an audio only, because they have found that a lot of elderly adults, and this may change over time as new generations that are familiar with video start to become elderly, but for now, a lot of them still do phone. They don't know how to use an iPad, and that's confusing for them. So it'll be interesting to see if there are different levels of reimbursement and whether there may be pushback from some physicians who are saying, well, wait a minute, I really want to see these patients in my office because of the economics of seeing a patient in the office versus telehealth versus audio. At the same time, I think it's going to be, patients pushing for trying not to come in if they don't have to. It's more convenient. I think the technology is getting better. There's definitely burgeoning technology companies that are helping out with these telehealth platforms, et cetera, that are going to be interesting. I think the other interesting part of telehealth, whether it's here to stay or not, is the advent of a lot of more mid-level providers, those nurse practitioners or those physician assistants that are doing the telehealth visits. That's another piece of this that may also stick around, whether we continue to see those folks on the front line. Things were moving in that direction. I think what COVID has done has been an accelerator for all of these things that were happening, but now have just been accelerated because you had to do them this way. And it's almost like an incubator to see what really works. Is dental telehealth really going to work and stay? The dentist I've talked to says, dentist, we can talk to you over the phone, but basically without really seeing your mouth and literally poking around in there, it's take an aspirin. If it doesn't go away, I'll see you tomorrow. So maybe that doesn't stick around. Physical therapy, on the other hand, maybe some of it can be done by telehealth, but if you're really going to manipulate a person, you might need to see them in person. So I think there will be different levels and different levels of who, again, will provide those services. Will we stick with a lot more physician assistants and nurse practitioners being our frontline people in this accelerated model that doesn't go back to normal, but is a new normal?
So I agree 100%. In terms of the mid-level providers providing care via telehealth, right? I think we've seen it. I mean, I'm here in New York, right? It's been done on a massive scale. Nobody seems to have come up with a real reason why we should roll back in terms of quality. And I think when I think about population health and access to care, this is a great tool to use, right? It drives down the cost of care. It makes care more accessible to people who might not otherwise be near a doctor, right? Think about rural folks. And I do agree that it'll drive, it'll be more impactful certainly with certain specialties, primary care, right? Mental health issues, your ability to see a primary care physician and then have that physician via telehealth make a referral so that you then go to a specialist, right? Those are going to be the real drivers, I think. And one other dynamic that I would throw out there, when we saw the advent of Nighthawk services in radiology, the technology allowed a physician, a radiologist, to view the same type of image or scan over and over and over. So you had this incredible specialty, expertise in a narrow type of image or issue. And I wonder if we'll see the same thing as telehealth rolls out, if you'll see providers directing the same types of issues and patients towards specific individual doctors or mid-levels.
I think that's could very well happen. I think the adverse of that, or the other side of that, is you may see telehealth for pre-authorizations, where you might have once gone to see your primary care physician because your knee had pain in it, but you kind of knew that the primary care physician was not going to solve your issue, but would help you figure out who to go to next. You could do that via telehealth now, save the actual in-person visit with the primary care physician, and then just move on to the next stage of healthcare. I mean, I think the final thing that might come out of this, which is telehealth related, but also just more general, is whether or not we will go back to old normal with respect to licensure of all of these different kinds of medical professionals, whether it be doctors or the mid-level providers. Right now, because of the concern that there wouldn't be enough workforce, a lot of the states, on a state-by-state basis, have changed their laws to allow people to come in from other states without being licensed in a particular state. And it will certainly be interesting to see whether that remains the same, or whether once the need has died down and there's plenty of need in a particular state, that state goes back to only permitting physicians or others who are licensed in that state to provide services in that state.
Yeah, and that is a genie that I could see very easily going back into the bottle. So I think telehealth, the discussion of telehealth lends itself as a pretty nice segue to the idea of pushing care outside of the four walls of a hospital or outside of a nursing home generally. And Julie, I'm sure you're seeing it in your neck of the woods also. But right now, people just don't want to go to a hospital, right? That's the last place they want to be. They're terrified of it.
Yeah, I mean, I have a particular client that asked us, they have, folks going out on the ambulances, and the ambulance gets to the 911 call, and the patient may be having a stroke or a heart attack, especially with some of the symptoms of COVID now, and the patient sees the emergency folks, but they don't want to go to the hospital. And so they actually asked us, can we hook up a physician who's at our hospital, who is there on call with the ambulance company, so when the ambulance comes out, they can actually have a telehealth visit on site with the physician, so that the physician will actually need to convince the patient to come to the hospital.
Yeah, it's incredible, right? I mean, I'm sure the mathematicians out there can figure out exactly, how much unmet care is actually out there, right? I mean, emergency departments just basically stopped. They were ghost towns during the month of April. So you have all of this pent up need. I think some of the things you could see migrating outside of the hospital, right? For one, people I think are going to like standalone ambulatory surgery centers, right? As opposed to going into a massive umpteen hundred bed hospital. I think you could see, back to your physical therapy idea with telehealth, right? That's a service that you might be able to deliver in the home. I think along with the telehealth, right, the digital health and the ability to transmit data both from the patient at home, but also from the provider back to the patient, telling that patient, do this, don't do that, check this, don't, that technology's, it gets better every day. And I think you'll see a huge push to deliver the care to the patient in their home, or certainly in their immediate vicinity, and try to keep these folks out of the hospitals, because I think it was just an issue of consumer demand.
I think that patients are going to want to be treated in their home no matter what, whether it's hospital, whether it's physical therapy, where there are developments, to match physical therapists with people in your home, where you can provide those services in the home, and thus you don't have to leave, and it's only a one-to-one interaction. You're not with lots of other people, especially if you're someone that's otherwise, compromised in your health. But I think it's going to become a boon for home health agencies, and what you might see is a lot more services being provided to those that wouldn't otherwise be homebound, that are going to want those services in their homes. There's a lot more remote monitoring that can be done now than ever before. And so I think you'll see, again, there was already remote monitoring that was done, and with technology, it was right on the cusp. And again, I think that this will serve as an accelerator for those services. I mean, even for hospitals, we're talking about people not wanting to go to hospitals. At least during the crisis time, hospitals are designating people's homes as outpatient departments of a hospital so that they can remain in their home, but the hospitals can still receive reimbursement for hospital provided care. And I'm not sure exactly, certainly there's been enough questions on the CMS stakeholder calls that I've been listening to with respect to how to do it, that there's certainly hospitals that are out there creating patients' homes as hospital locations. So all of that is going to be new and different, and will probably change the face of our care for years to come.
Yeah, no, so I agree 100%. It's another example of the crisis acting as an accelerant. Our firm represented a system that took people out of hospital beds, put them into their home in Oregon, and that was exactly what they did, right? They were providing essentially inpatient care at a person's home. And once you do it, and it makes sense, and it's a wonderful tool to have available, we almost have to see a push in that direction.
I also think you'll see the changing nature of nursing homes. I mean, obviously they have to change just generally for infection control purposes, but I think you'll see people trying to get that nursing home care in their home and coming out of a hospital and not going directly to a nursing home if they don't have to. I know, some of the studies when the government was looking at the comprehensive joint replacement study or bundled care studies that they were doing, a lot of that push in those studies where CMS was paying a global payment. And so you got to keep some of what you saved. A lot of that savings was coming, instead of sending people who needed to be in a nursing home directly to their homes and providing that care at home, because it's cheaper to provide that care at home. Again, I think you'll see that is going to become much more effective and much more accepted, because I think before people weren't so, sure about that, although it was a good cost savings measure. This is going to make it definitely more intriguing to folks to try and provide whatever care that can be done even after a surgery at home, rather than sending folks to a nursing home.
Right. And so maybe to pivot towards some of those cost savings measures, a lot of the state budgets, even with the stimulus money, right, those budgets are broken. I'm a New Yorker. We have a $15 billion state deficit right now, right? So what are we going to do? And it's like that line about why do you rob banks? Because that's where the money is, right? State governments, their biggest expenses typically, right, are healthcare and education. So we are girding ourselves, especially in the Northeast, for this wave of government spending or government cutting of spending. And it's going to be interesting, right? Because politically, the hospital stock has never been higher, right? They'll be king for a day at least. You're not going to see, I don't think you're going to see anybody in government move to close a hospital. If you would ask me the same question 6 months ago, sure, there were regulators in states all over the place looking to reduce beds and shut down facilities. So I think the hospitals are sort of king of the hill, but I think it's going to be a much smaller hill because the government spending is just going to have to get crammed down for budget purposes. There's just not enough money. What are you seeing?
Yeah, I'm seeing similar. I think that's going to affect Medicaid dollars and folks on Medicaid and how they're going to cut back on that. Certainly the hospitals have gotten the lion's share of the CARES Act funds that HHS has been giving out. I mean, certainly there are pots of money that have been given to rural hospitals or hospitals and other providers in hotspots, but because of the way they are distributing the funds, especially the first two general distribution tranches, which was based on your Medicare revenues from 2019, the entities and providers with the most Medicare revenues are obviously the hospitals. There's been some interesting articles in the Wall Street Journal and other places talking about how many billions with a B dollars those hospitals are getting from the CARES Act. That article was somewhat critical of hospitals, but hospitals also have a lot of overhead and a lot of expenditures. So I'm not sure that it fairly states that hospitals are sort of running away with dollars, and stealing things in the middle of the night. But I do think that they're getting a large majority of it. I think that this whole issue is not going to help mental health. I think there's a lot more dollars that need to go into mental health, and hopefully the crunch that I think you're right we're going to feel won't affect that and take us backwards, but rather hopefully in some ways propel us forwards on that. I do think the hospitals, because they are king of this small hill, will need to be careful to make sure that they're abiding by all of the various terms and conditions that the government has placed on the money that they're receiving. There are a lot of terms and conditions. There's been a lot of guidance that HHS has put out, some inconsistent over time, but the hospitals are supposed to attest to the terms and conditions, and they keep putting that date by which you need to attest back, because I think there's still a lot of questions about, certifying that you're using it in the right way and that you got the right amount. And so I think that is going to be an area ripe for people to look at. Did hospitals get the right amount? Whether it's politically, folks looking at that and seeing what is our healthcare policy saying, and also I think that there's a group of relator counsel, whistleblower counsel out there that are looking to ensure that if hospitals haven't done it in what they believe is correctly, that they're going to be at the ready to bring lawsuits against hospitals for taking money they don't feel was appropriate.
Right. Yeah, no, we see it the same way. We think the audit function around this money will be pretty vibrant. One of the things that you mentioned that I do see, and I hope we get this right, is as state budgets get squeezed and money comes, I think, from mental health providers and substance abuse treatment providers, developmental disabilities providers, what's going to happen to their budgets, right? And how are we going to take care of those subsets of people who obviously need a lot of care, more so now after a couple of months and in quarantine for a lot of the states, right? How do we take care of those folks given the budget distress? I'm smart enough to raise the question. I'm not smart enough to come up with the answer. But that I think is going to be a real challenge for politicians, and then ultimately for the healthcare system to navigate.
Yeah, and a lot of that's done by legislation, like the federal matching for Medicaid has increased during this period, and there's additional legislation pending to make it increase even more and for a longer period of time. And so I think that's going to be really critical to the points you're raising, to make sure that there's enough money. I mean, that sector of healthcare was underfunded before this happened. And I think you're totally right that with people having to stay inside and fear, there's going to be a lot more need and yet still underfunded. So something we'll definitely, hopefully, work on to get right in our country as we come out of this pandemic.
Right. So, I wonder, a possible way to out of the woods might be, to the extent that you're in a corporate practice of medicine state, right? Do those states loosen the reins a little bit and let private money into those ambulatory service areas? I don't know, but we're gonna need money, and the private sector might be where we need to go.
And it'll be interesting to see how much the private sector wants to fund these things. There was a lot of private equity money flowing into healthcare, but as we've all seen, one big, change can really affect those investments by those companies in a way no one would have predicted. And so it'll be interesting. Do you have any thoughts on whether private equity is still going to be as interested as before?
Yeah. So it'll be fascinating, right? So there are clearly winners and losers. There was plenty of press about some private equity investments into emergency services providers, right? And that fell off a cliff first quarter of this year. What we're seeing is you've got private equity backed practices, portfolio companies that are under some stress right now and need to figure out how are they going to restructure some of that debt. Okay, fair enough. There's plenty of debt in this landscape, right? But then you've also got some winners, right? You've got funds who remain cash flush, and they think that once we get back to something that looks like normal, there will be a lot of providers out there, independent providers, who will be running into the arms of acquirers because they can't stomach the risk. This was too bumpy a ride. They just don't have the cash flow to make it. So you've got some private equity buyers out there, right, who are going to take advantage of that. The other group of potential acquirers out there, and folks who are certainly very cash flush right now, are the insurance companies. So if you've got an insurance company that's already dipped its toe into the water and owns large physician practices, maybe they own a couple of hospitals, depending on where you are in the country, right? They've been taking in their premium checks. They have not been spending on elective surgeries for the last 2 months. So they should have loads of firepower if they want to go out and expand their networks.
And we were seeing that already even before this hit. So, the vertical integration of our health system, I think, is also something that is probably on the horizon, even more so than it had been in the past. Just because of the nature of what's been going on overall. And I think you're right. There are probably practices that have said, okay, I've been holding out, but enough with this. I don't want to have to, I don't want to have staff that I have to make sure that I can pay, and have on my conscience and responsibility. And so there's a lot of different pieces that could go into that. And at the same time, I see those same private equity and health insurance companies that have cash looking at technology in the healthcare space that can sort of run all of this better, whether it's referral management software or it's patient check-in, which is done in a way that is, touch-free and virtual, so you're not walking into a physician's office until you actually are walking straight back into your own exam room. All of that is probably ripe for folks thinking about deals at this point.
Yeah, no, I totally agree. The other pressure that I'd point out is that a lot of these providers, they're living off of advances that they recently received from CMS, right? Or they've tapped lines of credit. So if you think about like an ambulatory surgery center is kind of the easy example, right? So they've done whatever they've needed to do to reduce expenses. They've gotten their advance, they've tapped their lines, but they haven't had any cases for 2 months. So, the question is going to be, can they do enough procedures, right? Can they have the patient flow through when they do start the engines again, right? Can they generate enough cash to pay off that debt? And if they can't, what's the lender going to do, right? Most lenders hesitate before jumping into the healthcare business. It'll be interesting to see how this all plays out, 6 months from now.
Yeah, some of those Medicare advance payment dollars are due 120 days after the payment is made. And I'm already hearing folks that's, lobbying CMS that either should be forgiven or should be given a longer lead time for them to return that money.
Right. Which makes sense, right? I think it's fair to say that in the beginning of this crisis, folks didn't realize that we'd be putting the healthcare industry into this sort of stasis for 10 weeks, right? I think folks in their mind were thinking of a shorter timeline.
Agreed. So there's a lot that's going to go on. And I think a lot of new things will come out of this whole situation.
Yep. No, totally agree. Never a dull moment.
Never a dull moment.